Anna, and today is part 2 of our two-part series on IV diuresis. Please make sure you go back and watch part 1 first, as that will help the rest of this make a lot more sense. So let's say you have a patient admitted for acute or chronic heart failure. You admitted them yesterday and started them on an IV diuretic regimen. Next day you come in at 6 a.m., you're doing your pre-chart and with your coffee, and you see the values on the INO chart report. Unfortunately, we did not quite reach the goal of our -2 to 3 liters. You then move over to the labs and see, unfortunately, a lot of red arrows, despite repleting some electrolytes yesterday. What are you going to do from here? In this episode, we're going to talk all about how you manage the day-to-day in a patient admitted for IV diuresis. Let's start off with those electrolytes. As a quick refresher, loop diuretics work by blocking the NKCC transporter in the loop of Henle. This blocks the absorption of electrolytes, leading to their loss in the urine along with the water that follows them. This is going to trigger the activity of the renin-angiotensin-aldosterone system, as the patient is relatively volume depleted as we're getting more fluid out of them. Over in the distal convoluted tubule, the activation of the RAAS system is going to cause the presence of aldosterone. Aldosterone is going to increase the activity of the different transporters in the distal convoluted tubule and collecting duct, leading to more reabsorption of sodium and secretion of potassium. Magnesium is also dragged along in this process. This is why we have to aggressively repeat both potassium and magnesium when we're giving aggressive loop diuretics, because your patient's going to be losing quite a bit of those ions into their urine. For more details on how to replete these electrolytes, see our previous 10 clinical minutes episode on electrolyte replacement. One thing to consider is scheduling mealtime oral potassium chloride when you're doing IV diuretics 2 or 3 times a day. This can help prevent your patient from getting too depleted of their potassium. So that's a pretty good way to go ahead and prophylactically give your patient some repletion, anticipating that they might have some lows with the loop diuretics. Moving on to the issue of your patient not quite meeting your INO goal. Loop diuretics have a threshold, a dose response, and a ceiling effect. Below the threshold effect, you're really not going to get a whole lot of diuretic effect. This threshold can be as low as 5 or 10 milligrams in patients with normal kidney function, or as high as over 100 milligrams in a patient with CKD stage 4 or 5. You then get a dose-related effect as you increase your dose, but eventually you'll reach a ceiling effect, above which no additional effect is going to be noted by increasing doses, but you will have increased adverse effects with those increasing doses. This ceiling is higher in CKD because less of the drug gets to the kidney, where it's metabolized to its active form. It's really important to understand this threshold and ceiling effect of loop diuretics, because when you're adjusting your doses, you need to realize that you want to go for higher doses less frequently as opposed to lower doses more frequently. You can have the same daily dose with dramatically different effects based on these thresholds. For example, if you have a patient on 40 milligrams of furosemide twice a day, you might only get an INO of -600, which is quite under goal for an inpatient. If, however, you transition that to 80 milligrams once a day, you might get a much better response of -2 liters because you better breach the threshold for that specific patient. Let's say you're in the situation where you're giving pretty high doses multiple times a day, let's say 80 milligrams IV 3 times a day. At that point, you might need to move on to a constant drip. This is typically abbreviated as GTT, and that comes from the Latin word gutta, which means drop. This is when a patient is at a constant rate of that IV diuretic rather than bolus dosing. Bolus dosing works by having peak times of natriuresis, but in between those boluses, you're going to actually have some sodium compensatory retention. A drip gets around this by having a constant infusion, leading to a constant diuretic effect while it's going. This also has a constant inhibition of that sodium reabsorption, leading to having much more effective natriuresis or diuresis throughout the day. The effects tend to be the best when you start with a bolus dose, followed by a constant rate of the medication. The dosing really depends on the individual patient's clinical picture and their threshold. But a good rule of thumb is that you can start at about 10 milligrams an hour of furosemide, and you can go up to as high as 40 milligrams an hour. An extra bonus of that drip dosing is that you'll have less of an impact of adverse effects. If you think about it, the equivalent bolus dosing of the total daily dose from an equivalent drip rate would have huge boluses, and that could put the patient at significant risk for things like ototoxicity from the loop diuretic. We can get the same overall effective, if not better, diuretic effect, but with less risk of the adverse effects that come from those really high peaks that we would get from the equivalent bolus dosing. If you're doing a drip and it's still not quite cutting it, you can try something with thiazide augmentation. The reason this works is because with loop diuretics, we're hitting that loop of Henle, which we know is the most powerful spot to be able to hit with a diuretic. But as we talked about earlier, the blocked sodium in water is then going to go downstream where it's going to see that distal convoluted tubule, and there's still points that it can be reabsorbed there. So if we instead block that part of the nephron as well with a successive nephron blockade, we're going to get more effective diuresis. In that distal convoluted tubule, we have a sodium-potassium pump powering sodium chloride reabsorption. Thiazides work by blocking that sodium chloride reabsorber, leading to more effective diuresis as we lose the ions in the urine. When we're talking about an inpatient setting, we're really going to need an IV thiazide, most commonly which is going to be chlorothiazide, or the brand name you'll hear is Diureal. One thing to note is that Diureal can be pretty expensive IV, so it's a good tool to be able to use, but don't reach for it if you don't have to. Next up, we're going to talk about the case of the creeping bicarb. When you're giving a patient this aggressive amount of diuresis, you will see that bicarbonate go up day to day. If you've seen our metabolic alkalosis series, this might be ringing some bells. There's too much detail about the physiology to go over now, but I encourage you to go back and watch those videos to understand the phys. Long story short is that acetazolamide is your friend in these situations, especially if a patient is a chronic retainer of carbon dioxide, such as in COPD or obstructive sleep apnea. You really need to be careful with aggressive diuresis because that could cause them to retain too much CO2, pushing them into apnea when they're sleeping. A good rule of thumb is that if their bicarb on the metabolic panel is getting above 30 to 35 on their morning labs, you can give them a dose of 500 milligrams of acetazolamide in the morning. And then when you recheck labs in the afternoon, you can redose at that time. If their bicarb is greater than 37 to 38, you can go ahead and give them about 1,000 milligrams. IV dosing is quicker onset and tends to be more effective than oral, but you can use oral if you need to. Another thing to keep in mind when you're talking about inpatient dosing is to be mindful of the duration of the diuretics. It's hard enough for our patients to get sleep in the hospital, let alone if we're making them stay up all night to pee. Think about the duration of the diuretic when you're choosing the timing for your evening doses of diuretics. If you're using oral doses, if they give the dose at about 4 p.m., you'll have that effect through about 10 or so at night. So giving that dose at 4 as opposed to at 6 will help your patient be able to sleep. If you're giving IV doses, if you give the last dose at about 5 p.m., the effect will start to wear off around 7 or 8 p.m., again, letting your patient sleep. If you have a constant drip going, think about pausing it overnight at like 8 or 10 p.m. After you pause the drip, the effect will last for 2 to 3 more hours, so it'll allow your patient to sleep at least for a few hours overnight. In some of our patients, especially in the ICU, you might need to keep that drip on overnight to reach your diuresis goals. If this is the case, consider placing a Foley temporarily or an external catheter so that your patient doesn't have to get up out of bed all the time to pee overnight. Finally, I want to mention something that I like to call loop myalgias. This tends to happen in patients getting aggressive diuresis. It tends to be a fairly diffuse kind of muscle ache, not so much a pain, but just kind of an ache. We think that this is secondary to interstitial fluid shifts that happen as we're slowly getting the fluids out of their interstitial space. It's also likely got a component of electrolyte shifts creating this pathophys. There's really only 2 ways to treat this. One is to slow down the rate of your diuresis if you're able to do that based on the patient's clinical picture. Another is just to make sure that you are aggressively repeating those electrolytes. This can help both prevent and treat the loop myalgias. So in summary, when you're giving a patient aggressive IV diuresis, really make sure to watch those electrolytes and replace them aggressively. Loop diuretics have both a threshold and a ceiling effect. So when you're choosing a dosing regimen, choose to dose more at once rather than less at multiple times. And be aware that you have to breach that threshold for a patient. If you're giving a patient IV loop diuretics 2 or 3 times a day and it's just not cutting it, consider changing to a drip dose or a GTT constant infusion. But be mindful of dosing times when you're thinking about a patient's ability to sleep. Consider dosing earlier in the afternoon or pausing the drip overnight so that they can sleep. Thanks so much to my advanced heart failure cardiology attendings, Dr. Sauer, Gupta, and Highland. If you enjoyed this episode and found it helpful, please like and subscribe. You can also find our website at decodingdx.com where you can see past episodes and show notes. As a quick reminder, everything in this episode is for educational purposes only and is not intended for medical advice. Thank you so much, and we'll see you next time.